Hello, and welcome to Dollars, Cents, and Value in Medical Decision Making. My name is Lauren Walker, and I created this module in collaboration with Drs. Jennifer Rama and Stephen Whitney. The objectives of this module is to increase physician awareness of their role in the rising costs of healthcare in the United States, to equip physicians with the tools needed to practice high-value, cost-conscious care, and to recognize that the changing healthcare landscape will lead to increasing demand for cost transparency. Let's focus on our first objective, to increase our awareness of our role as physicians in the rising cost of healthcare in the U.S. So as many of you know, the healthcare spending in the United States in 2012 was estimated to be $2.8 trillion. And that's the same as about 18% of our gross domestic product. Of that $2.8 trillion, about $250 billion were spent on clinical tests that could have been avoided without affecting healthcare quality at all. And on top of all of this, physicians' own medical decisions, those decisions they make on a daily basis, account for about 66% of healthcare expenses. So knowing that there is unnecessary cost and unnecessary testing in healthcare, and that 66% of this is accounted for by physicians' decisions, then it's really important that educational interventions be developed to assist physicians to consider costs in medical decision making. But let's look at these numbers in a different way. So if you look at this graph on the left, the graph on the left shows average spending on healthcare per capita. And the black line that you see here is the United States, whereas the multicolored lines here represent similarly industrialized countries, such as France, Norway, Japan, New Zealand. And if you look here on the x-axis, this shows that from 1980 to 2009, healthcare costs have increased across the board. However, average spending on healthcare per capita in the United States has increased at a rate out of proportion to these other countries. And then similarly, the graph on the right shows total expenditures on health as a percent of the GDP. And again, the black line represents the United States. The multicolored lines are other countries that are similar to the United States. And again, the United States continues to spend more, and that spending is increasing at a rate greater than the other countries. So we've demonstrated that healthcare spending in the United States is more than other countries and is increasing at a rate faster than other similarly industrialized countries. But does that translate to better outcomes? Unfortunately, it does not. One of the metrics that exists to measure healthcare quality is life expectancy. And if you look at this chart, this green line here shows the average life expectancy in the United States in 2011 to be about 78.7 years. And again, this is comparing, the blue lines represent other similarly industrialized countries, and all the way to your left you have Switzerland, who has an average life expectancy of 82.8 years, and you have Japan, followed by Italy, Spain, and Iceland. And so this graph shows you that the United States, despite all of this extra spending, does not have improved health outcomes. So what is the source of this extra spending? Well, about $700 billion per year of healthcare waste occur. And when broken down, it looks like a portion of that is caused by pricing failures. There's also a component caused by a lack of care coordination, so the different silos of medicine aren't communicating with each other. There's also provider insufficiency and errors, and that just refers to medical errors that occur. There are administrative system inefficiencies, so for example, a lack of electronic medical record. Unfortunately, there's also some fraud and abuse, which causes healthcare waste. And then last but not least, the area that I want to focus on during this presentation is unwarranted use. And unwarranted use, as we mentioned in our introduction, accounts for about $250 billion a year. So we're about to talk about what causes unwarranted use in healthcare. And as we talk about these, I want you to just pause and reflect and think which of these apply to you the most, and which of these reasons sometimes drive the decisions that you make when you're practicing on a daily basis. So first of all, there's a fear of diagnostic uncertainty. And that's both on the part of the physician who feels really uncomfortable not providing a diagnosis to a family or a patient, and similarly, a patient often feeling uncomfortable with the unknown and not having a concrete explanation for what their problem is. And so a lot of times, even when an explanation or a diagnosis is impossible to find, tests are still being performed with the hopes of reaching that diagnosis. There's also a lack of experience, so younger physicians tend to order more. And then there's also the situation where certain tests and procedures just become routine and they get ordered automatically, kind of like a knee-jerk reflex without necessarily a lot of forethought, and it becomes a habit. And then on top of that, there's an inadequate educational feedback which occurs. So oftentimes during residency, people aren't given the feedback that the test that they ordered wasn't necessarily needed, and so it becomes a part of the routine clinical practice and it's perpetuated. Additionally, clinicians in general lack knowledge about the costs of the tests and medicines that they prescribe, and studies have shown that when clinicians are provided with that knowledge, they actually tend to order less. And then lastly, we do live in a litigious society, and that drives defensive behavior on the physician's part because they want to order as many tests as possible sometimes to make sure they're covering all their bases. So does this matter? Are there any consequences other than just driving up healthcare cost? Well, unfortunately, the consequences of excess ordering are more than just monetary. It results in inefficient resource utilization, and then you also have the risk of false positive results. So for example, if you send in a patient for a CAT scan of their chest and you discover a nodule on the lung, and it's small and you don't really know what to make of it, but you decide it should be followed. So then that means the patient takes on the psychological burden of knowing there's a spot on their lungs. They may or may not have cancer or some other problem. You decide to check again in 6 months. So that repeat test is another financial burden. But then the patient's also being exposed to radiation. And so you're causing unnecessary patient discomfort, plus physical harm from the radiation, and more financial cost to the patient and society. So what has been done in the past to try and limit cost? Well, they've attempted to ration tests. They've also tried panel testing, so clumping tests together, educating physicians about the cost of tests, though that's difficult because there's a lot of opacity around how much tests actually cost, and we'll get to that in a little bit. Guidelines have been developed and protocols to help provide guidance to physicians as to what should be ordered when. There's also peer review by experts and feedback about ordering behavior. So in other words, there are often peer committees within one's hospital who will review data and actually sit down with the physician and let them know how their ordering habits compare to others, what their strengths are, what their weaknesses are. And then lastly, there's also been a new movement to try and encourage physical exam skills of the physician, so they have to rely more upon their physical exam skills rather than diagnostic tests and imaging studies. And just think to yourself, have any of these proven particularly effective? So now I'd like to move on to our next objective, which is to equip physicians with the tools needed to practice high-value, cost-conscious care. So let's talk about high-value, cost-conscious care first and foremost. What exactly is it? It's the concept that you're providing the best possible care to your patient, but at the same time minimizing unnecessary costs to society. And let's define a few of these terms. What exactly is value? I know that's a really nebulous term and something hard to wrap your head around of. But think of it this way. So people tend to buy something based on their perception of what the quality of the item is, how much it costs, and then they look at and compare it to what's the next best thing that their money can buy. But the problem in medicine is that quality is really hard to measure. We don't have any great quality metrics. And then on top of it, costs are very hard to define, they're opaque, and then costs get distorted by insurance. Another way to consider value is to say value is the same as quality over cost. But I think it's important to point out that something that is high cost can still have high value. So for example, if you have an infant who rolls off the bed and is acting sleepy and lethargic, a CAT scan reveals an epidural bleed, then that is a high cost test that still has high value. On the other hand, if you have a child who comes in with asthma and a CBC is drawn, it's a low-cost intervention, but it has very little value in this clinical setting. And it's also important to remember that unnecessary tests have negative value. So let's talk about cost a little bit. I referenced this earlier, but cost is not just monetary, and it just doesn't refer to the charges that the hospital might charge. It's something that's immediate and it's delayed and it's multifactorial. So it's financial, it's psychological, and it's physical. So let's put these concepts together and let's look at our cost value curve, which you'll see commonly used in economics. And right now in healthcare, there's a phrase that gets floated and it's called bending the cost curve. And what this is saying is that if you look at your x-axis here, you look at your x-axis, your cost increases in this direction, and as your cost increases, your value increases. And when we say let's bend the cost value curve upward, what we're saying is that for this cost here, you want to go from getting this much value for your dollar up to this much value. So for the same amount of money, you want to be increasing the value that you are receiving as a result of it. I want to be very clear, however, that high-value, cost-conscious care does not equate to denial of care or rationing. It does not say or does not mean that somebody should be denied a service that they need just because it costs a lot of money. Instead, it means that we should be mindful of our ordering and prescribing habits in a way that we're trying to minimize unnecessary spending in healthcare. So how do you order mindfully? Let's talk about some of the tools that we have in our toolbox to use. First, there is a sequence of steps, a mental exercise that you can go through, a framework that you can use to be conscious and aware of your ordering habits. And these steps were initially developed by the American Board of Internal Medicine and the American College of Physicians, who developed the concept of high-value, cost-conscious care. So step one, you want to understand the benefits, harms, and costs of the interventions. Step two, you want to try and minimize the use of interventions that have no benefit. And then step three, you want to choose the interventions which maximize benefits. So those make sense. The next two steps I think are a little bit more novel. So step four suggests developing a care plan alongside the patient that accounts for their values and wishes. So that means that you're going to be engaging the families in a discussion and engage in shared decision making with them. And then the last step is at a broader level, but it's to identify and address errors within the system which result in harm and waste. So you're moving from your individual encounters and looking at the big picture and the system of healthcare as a whole. So there are individual questions that you can ask yourself before ordering a test. You can ask yourself, has this test been performed before? I know in my institution, a lot of times a patient will get admitted from another emergency room or from another hospital, and they may have a lot of labs and tests that came with them, but we end up repeating them somewhat out of habit or because the labs got lost in transit, but that's an unnecessary cost. The next question to ask is, how will the result change the care of the patient, if at all? Because if you frame it that way, then it helps remind you that it might not be needed. So for example, we have patients who present to the emergency room and they have viral testing done. And a lot of times that viral testing won't come back for several days, even though the patient's fairly well appearing and might get discharged home from the emergency room that day. And the results of the tests won't affect their management. A next question to ask yourself is, what would be the consequences of a false positive result? So what other testing, what other psychological harm could come of that? And then, does not performing the test harm the patient? And lastly, am I ordering the test because I feel it is needed, or is it to reassure the patient, or even sometimes to reassure yourself as the physician? So again, with mindful ordering, just know that ordering unnecessary tests can be expensive, it can lead to other complications and discomfort. And one tool that we have out there are outcomes-based guidelines that help minimize unnecessary testing and expense. So let's talk about how to find the clinical guidelines here at Texas Children's. So first of all, at the Texas Children's intranet homepage, you're going to go over to the Resources tab. You'll click here, and you'll go down to Clinical Resources. Click Clinical Resources, and then navigate over to Clinical Guidelines. Click on Clinical Guidelines, and then here you'll see that they have a whole list of the available guidelines and order sets. So everything from asthma to acute heart failure to diabetic ketoacidosis, rapid sequence intubation, so on and so forth. They also provide evidence-based summaries below this to explain why they make the recommendations that they do in their clinical guidelines. So another resource that is available to you as a clinician are the Choosing Wisely recommendations. So this was a campaign undertaken by the American Board of Internal Medicine in conjunction with the American Academy of Pediatrics. And they published 5 things that physicians and patients should question, with the idea that we should try to minimize overuse in healthcare. Their first recommendation was that antibiotics should not be used for an apparent viral respiratory illness. They also recommend that cough and cold medicine should not be prescribed or recommended for respiratory illnesses in children under 4 years of age. Also that computed tomography or CAT scans are not necessary in the immediate evaluation of minor head injuries. Neuroimaging is not necessary in a child with simple febrile seizures. And also that CT scans are not necessary in the routine evaluation of abdominal pain. These were so popular that then they published 5 more things that physicians and patients should question. Again, along the same lines. So things such as don't prescribe high-dose dexamethasone for the prevention or treatment of bronchopulmonary dysplasia. Don't perform screening panels for food allergies without previous consideration of medical history. Avoid using acid blockers and motility agents for reflux in infants, and avoid the use of surveillance cultures for the screening and treatment of asymptomatic bacteria. And then lastly, home infant apnea monitors should not be routinely used to prevent sudden infant death syndrome. What I want you to know is that these 10 points are available to you as a clinician, and that you're able to provide these to the family if they ever have questions in handout form. So we've just talked about how to mindfully order diagnostics rather. And now I think it's important to talk about mindful ordering of medications, or in other words, mindful prescribing. So first of all, it's really important to prescribe with the individual's insurance in mind. So what are the issues that arise from insurance ignorant prescribing of medications? Or in other words, prescribing medications that are not on an individual's formulary? Well, first and foremost, there is a financial repercussion. So families may pay more than necessary for the meds. There's also the fact that treatment could be interrupted or delayed. So when the family goes to the pharmacy and tries to get the medications filled and they're unable to do so, then the patient might miss 24 hours of medicine while it's waiting for authorization from the insurance service. It's also just bad customer service for the families. So what are practical things that you can do? Well, to begin with, you can look up their insurance and you can consult their formulary, often through online searches. So for example, you can look at the Medicaid formulary at this website. You can also empower your patients and families. Encourage them to have discussions with the other doctors in their care team. Make them aware of their insurance issues if they have any. have them place phone calls with their insurance companies in advance to try and figure out what they might need. You can always call a pharmacist and ask for help, and if you're on the inpatient side, the care managers on the floor are often very helpful in these situations. You can also remember that generics are a prescription possibility and are often highly appropriate. And remember too that for Medicaid patients, certain over-the-counter supplies such as gauze or an antipyretic such as ibuprofen are free with a prescription. And also remember that there's the $4 drug list available for use. So places like Costco or Sam's, Walmart, Target, and now even CVS and Walgreens have a lot of generic medications available for $4 a month. And sometimes this is actually even cheaper than for individuals with insurance. So this is cheaper than what their copay might be. There are also a series of questions that you can ask yourself to achieve high-value prescribing. So the first question is, how necessary is the medication for this patient? Is this something that could be treated with diet modification? For example, you have a patient who's a borderline diabetic, and rather than necessarily starting them immediately on metformin, you can start with dietary modifications and exercise, and then just monitor closely. The next question to ask is which medicine is the most efficacious and safe for the patient and on their formulary? And then lastly, is it appropriate to use generic instead of brand name in this situation? Again, usually generic and brand names are equally efficacious and safe. And so if a generic is available, then often it can be used in place of a brand name medication. Now let's focus on our last objective, which is to recognize that the changing healthcare landscape will lead to an increasing demand for cost transparency. So to explain this, I want to talk to you a little bit about the Affordable Care Act, particularly since I think as a lot of the physicians, we don't know very much about the ACA. So first and foremost, the goals and the aims of the Affordable Care Act were to increase access, decrease cost, and increase quality in healthcare. So let's talk about how the ACA improves access. First of all, it creates insurance mandates that no one can be denied insurance due to a pre-existing condition. The ACA also requires coverage of dependents by insurance companies up to age 26. And then additionally, it encouraged, though it did not mandate, Medicaid expansion at the state level by broadening eligibility criteria, and then also by saying that the federal government will pay 100% of the cost of new enrollees between the years of 2014 and 2016. However, not all states have decided to expand Medicaid at this point in time. The other way the ACA trying to improve access is by the creation of insurance exchanges. So the exchange is a state-run marketplace where anyone can purchase private insurance. So anyone from the most wealthy to the most poor can come in and buy private insurance. Now, those who have incomes up to 400% of the federal poverty level, so people who make too much money to qualify for Medicaid but are still relatively poor, they actually receive money from the federal government that they can use to purchase private insurance on these exchanges. The caveat being that the plans vary in the amount of deductible and copay. So if you look at this slide outlines the different levels of plans available through the health insurance exchanges. So at the bottom of the pyramid, you have catastrophic. Those are your really basic plans. They're limited only to healthy individuals less than 25 years of age, I believe. Your next level up is bronze, then silver, then gold, and finally platinum is at the top. So the plans toward the bottom of the pyramid in general will have low monthly premiums and high deductibles. So meaning they're not paying a lot on a monthly basis, but then if they do get sick and require health care, their deductible, their out-of-pocket expenses will be high because their deductible is high. This contrasts with the platinum plan at the top, which has a high monthly premium and a low deductible. So now let's talk about how the ACA decreases cost. Well, one way is through changing reimbursement patterns. So traditionally, physicians have been paid by fee for service. In other words, for every exam performed or procedure completed, they are paid a certain fee. There's now a movement toward bundled payments and lump sums for episodes of care. So in other words, physicians are being paid a lump sum of money for a specific patient encounter over a specific period of time. There's also a move toward pay for performance. In other words, being paid for the quality of the healthcare that is being provided. Unfortunately, that gets a little fuzzy because, especially in pediatrics, there aren't any great quality metrics, but it is a work in progress. The ACA also incentivizes preventive services by making well child checks free for families. And then lastly, the ACA is trying to improve quality, and they're doing this by encouraging the creation of ACOs, which are accountable care organizations, which are organizations that are trying to break down the different silos in healthcare and encourage collaboration between the different sectors of healthcare. The ACA also establishes commissions which research quality improvement measures. And then lastly, as I mentioned in the last slide, they're trying to link reimbursement to quality outcome measures, with the idea being that you're incentivizing quality. So what this means, though, is that under traditional managed care plans, so your HMO, your PPO, a $2,000 test traditionally will have an out-of-pocket cost of $25. And so there's little incentive for the patient to limit tests and to be mindful of how much things are costing. But under new high deductible plans, so the bronze plan that I just showed you, a $2,000 test is often going to have an out-of-pocket cost of $2,000 if the deductible has yet to be met. So bottom line is that this creates a demand to know costs in advance. So that means families are probably going to be coming to you wanting to discuss costs. And how do you engage in this conversation with them? Because it's a fairly novel thing for us as physicians. Well, first of all, it's important to just be transparent, honest, and clear. You can use guidelines to help support what you're saying and explain your thought process. Try to minimize any kind of medical jargon, and then share with them what you're thinking. Discuss the risks, discuss the benefits, and be as transparent as possible with your thought process. It's important, too, to help solicit their concerns and worries, and once you're able to identify their concerns, then provide empathy. Explain to them that you understand, and again, explain to them why you're thinking what you're thinking. And then you can use a team-based approach to help assist you with this. If you're on the inpatient side, a lot of times you have social workers, financial counselors, and care managers that can help you along this process. And also remember that families are a vital part of the team, and they are very much a part of the decision-making process as well. So the bottom line is that you should be prepared for parental demand for cost transparency moving forward as we encounter these healthcare changes. There are a few barriers to transparency. So there's regional variation between different geographic sections of the United States. There's institutional variation. So even within one city, different hospitals might charge different amounts of money. And then insurances also have different reimbursement rates and different contracts with individual hospitals. And so it's very hard to get down to how much an actual test is going to cost. So knowing, though, that there's an increasing demand for transparency, some tools have emerged to help you try and get to the bottom of it, to help figure out how much do these tests actually really cost. Again, if you're on the inpatient side, hospital resources that you have available are individuals such as your case managers, your financial counselors, and in places like Massachusetts, Oregon, and New Hampshire, they have now developed state-run databases which require that hospitals report the costs of various tests, procedures, and so on and so forth, and that is documented in these publicly available databases. For those of us who don't live in those states, there are some internet resources available, such as healthcarebluebook.com, newchoicehealth.com, and fairhealth.org. And these are websites where you can go and put in the name of your test and your zip code, and they will actually estimate the cost of the test for you. And then lastly, insurance companies are also aware of this issue, and they have developed cost estimators. So for example, a patient can go to United Healthcare's website and actually come up with a cost estimate for a potential procedure. Again, this is much easier when it is a chronic or a non-acute issue, because when somebody is going to the emergency room, in theory, they're not going with the ability to anticipate how much it's going to cost. So here we are at fairhealth.org, which is one website and one tool available to consumers to estimate their healthcare costs. So let's walk through this website together. So here we are on their main page, and let's pretend we want to get an MRI of our brain. So you're going to click on medical. Start with get started. And the first step, if you remember, I said that there was some regional variation in costs. So the first step is to enter our zip code. The next step is to answer if you are insured or uninsured. And for the sake of this demonstration, we're going to say that I'm insured. And then our next step is to enter the procedure code. Unfortunately, I don't know the procedure code off the top of my head. So alternatively, what I can do is scroll and go to imaging tests. So we click on imaging tests, and oh look, there's the MRI. Then we have brain and nerves. So click on that. They want us to read their terms of use, which I agree to. And then here I can select an MRI scan of brain before and after contrast. So we'll click here and then see what our result says. So if you'll see here, it says estimated charge is $715. Estimated reimbursement is $501. And so that leaves me with an out-of-pocket cost estimate of $214.79. Now the disclaimer being that this does not account for the cost of the radiologist. So this does not account for how much it will cost for the radiologist to read the MRI. So now let's summarize the tools that we've talked about, the tools that we can use as physicians to practice high-value, cost-conscious care. So for investigations, meaning the ordering of diagnostics, tests, so on and so forth, you want to ask yourself 5 questions before ordering a test. You also have evidence-based guidelines and protocols available. And then also remember that it's a multidisciplinary team approach. Then you can use your social workers, case managers, and financial counselors. And then lastly, you have available online cost estimators through both the public websites that I just showed you, as well as through insurance companies. For medications, or to prescribe mindfully, you want to walk through the 3 questions before ordering a medication. You want to try and choose formulary medications. Be sure that you prescribe generically when appropriate. Use the $4 drug list when you can. And under Medicaid, know that for some over-the-counter medications and supplies, they can be free with a prescription. So in summary, physicians have a role in the rising cost of healthcare, and we as doctors, we can play a role in helping reduce healthcare waste. You now have tools presented here to help you practice high-value, cost-conscious care. And remember, it is a team approach, and a variety of tools will be needed at different times. Knowing this and anticipating a consumer demand for cost transparency due to the Affordable Care Act moving forward, you too will be able to practice high-value, cost-conscious care.